Panel 2, the good, the bad, and the ugly, empowering patients to implement research evidence. So it's a good follow-through on the conversation that we just had. Okay. So our next presenter is Dr. Richard M. Rosenfeld, MD, MPH, who I call the parent, I won't make it gendered, the parent of effective guideline development. He certainly has been a mentor of mine. I participated as a consumer in 4 guideline development panels at the at otolaryngology head and neck surgery, and also we also have Lorraine and Chetta in the audience today, who's going to be in a workshop, who's the mistress of guideline development, and Dr. Rosenfeld has an incredible background in this, and really with Dr. Alan Schiffman, really what I consider he wrote the book on the best and gold standard of guideline development, including many stakeholders and consumers. So I'll just turn it over to him.
All right. Well, good afternoon, all. Look at this lively group. You see, that's where you go to find lively people, a Q meeting, you know. You go to all these medical meetings, they're all like comatose by now, so this is, especially postprandial, so you guys are good. Must be Barbara keeping you all awake or something, you know. So, no, it really is a pleasure to be here. Thank you, Barbara, for the very kind words. And Barbara was, don't tell anybody this, my favorite consumer ever on guideline panels, you know. And Taddy is one of my favorite Cochrane and evidence people also. So it's nice to be here with all sorts of fun people and talk about a fun topic. My background is I'm an ENT guy, so I spend my days like looking at kids' sinuses and pulling out earwax and, you know, telling parents why they really should keep their tonsils and not take antibiotics and do all these things. But the real fun in life is guidelines, because you get to meet interesting people, get invited to Q meetings, and it's really a fun thing. Who here has served on a guideline panel other than Barbara? So a couple of you. Now, did you have fun? I don't know. Or did you get abused?
Both.
I've heard both. So we want to step up our game so you get the former, not the latter. All right. So as Barbara mentioned, I actually this morning was just in Alexandria, Old Town, which is where our headquarters is for the American Academy of Otolaryngology Head and Neck Surgery, the ENT folks. There's 12,000 of us floating around. If you ever want to have fun, come to an ENT meeting in September where you can hang out with like 9,000 ear, nose, and throat folks. I mean, it's actually, don't do that. You don't want to do that. It's not a good way to have fun, but it's fun for us at least. But we're right down the block there in Alexandria, and we've been fortunate in that starting about 11 years ago, our academy really got serious about developing guidelines and devoted a lot of resources to it, and it's been a lot of fun. So the standards were mentioned. The guidelines themselves, the definition changed in that it's supposed to optimize care. Systematic review is built into the recipe now, and you're supposed to have some active process of thinking about benefits and harms and then making decisions. So that's kind of boring stuff. So when we do guidelines at our academy, after we give birth to a guideline, which we do pretty rapidly, it's not 9 months, but it's close. It's actually about 14 months, 16 months these days from conception to publication. They get a page. And they get a page in the internet, and this one is a recent guideline. It was just published in 2016 on fluid buildup in kids' ears, which is kind of like an occupational hazard of early childhood. If you occupy early childhood, you get this to some extent. It's the #1 reason kids get surgery in the US, the little ear tubes. It's a big deal. So we always include lots of stuff for patients. So we have a plain language summary, all sorts of handouts, understanding ear fluid. They all get massaged down to the right reading level. The consumers are very actively involved in these, how to talk to your doctor, decision aids. So we try and be very proactive on our resources with the guideline and think about patients the whole way through, not just as an afterthought. And you know the standards that says you guys should be there. Patient, public should be there. Or at least at the time of clinical formulation. I think they're really wimped out on that one. You guys should be there the whole time, right? You don't want to just be there thinking about a question and then trust some doctors to figure it out. No, you can't do that, you know. current or former patient, an advocate. We've used many. We've used patients, we've used advocates, we've reached out to advocacy societies all different ways, but our favorite source of consumers is you'd never guess where. Q, of course. We beg and plead and they come, usually. Okay. And I really enjoyed Vivian's presentation. These are older data, but it seems to be echoing the same theme, that if you look at published guidelines, in general, they found that 17% had some patient or representative, and if you go to the US, it's a whopping 7%. The international community is definitely ahead of the US in this area. I mean, it's pretty depressing. So why could this be? Why is the US thinking this way? Well, in preparing for this talk, I did my usual literature search. Not that I typically read the International Journal of Urogynecology on a regular basis, but if I did, I would have seen this very depressing article. Think about those troublesome patients in public. Do you really want them on your guidelines? Of course, it's a narrative review, so we can't believe it, right? If it was systematic, they'd have a different conclusion. But they said all sorts of things in here, like, wow, there's hardly any evidence to show that those pesky consumers need to be there. There's no proof of effective outcomes. All this optimism, why are you guys so optimistic? We got to reconsider that optimism. And, the anticipated impact, it's just so disappointing, right? Isn't this nasty? Oh, these awful people. So where'd they get this stuff from? So I looked up a couple of the key references. So here was one from the UK. This was a systematic review. Patient and public involvement. It impacts a lot, but there's little evidence it really does anything to the cost or economics, and few studies really define it. There's a lot, very limited theoretical underpinning. It's not conceptualized well, as I think Vivian just hinted at. So, wow, maybe it isn't that good. We can save money, Lorraine, if we get those consumers off the panels. It'll be two less mouths to feed and, house in the hotels. And here's another one from Utrecht, where they usually do good stuff in the Netherlands. I know a lot of people in Utrecht, and they did a systematic review there and concluded that, yeah, everybody says do it, but, it's based on an assumption that putting those patients in is really going to do something good, and there's little empirical evidence to support this, right? Wow, this is really uplifting so far, I know. Okay. So I think you need to think about something William Osler said a long time ago. And he said that common sense in medical matters is very rare and generally an inverse ratio to the degree of education. So if you stock your guideline panel with all those subspecialists with 18 degrees and certifications in this, all your common sense is gone, okay? Now, not to say that consumers don't also have degrees and PhDs and other things, but you need people with common sense. And I think anybody with common sense would look at those previous studies and conclusions and say, you got to be kidding me. I mean, this is mom and apple pie. It's like saying, well, there's no good evidence that reading to your kids when they're young is really going to make them smarter. All right, that's it. I'm not reading to my kids. It's like, the parachute studies, about parachutes. Come on, this makes sense. And I think you got to have consumers, if you want your guideline to be relevant to patients, to consumers, to make sense. They're the ballast that keeps everybody in order. GIN itself, the Guideline International Network, did their standards. They did mention consumers. They actually mentioned patients as one word in what should be in a guideline group. Not exactly a ringing endorsement, but they did at least say that patients should be there. So what are the possibilities? We heard a little, and this is a slide I stole from Antoine Boivin, who's one of the folks that founded GIN Public. We can talk to consumers. So we do a guideline, and then we say, here's our guideline, follow it, isn't it great? That's probably not the best way. We can consult. We're doing the scope, we're developing questions, we want your feedback, we send it out to you, tell us what you think, maybe we'll use it, maybe not. The better way is to be on a group, to be a full part of the process. So those of you who raised your hand before, you actually in the guideline development groups. Mm-hmm. You were there in the trenches. Good. So I think that's important because, what do you add? Hopefully, if you're awake, you're passionate. You give us perspective. Most consumers, once they get going, are real skeptics. Of course, Barbara's not that. Barbara's like groupthink. She's not a skeptic. She would never do that. But they're a good challenge to the docs. You know, consumers tend to think about harms, adverse events, risk. You always want to educate the patients and make shared decisions, and it's good to have a little gadfly that keeps telling you this stuff during the process. Now, how do you do it? You know, we put them on groups, but I thought this was interesting. Came from Sydney, Australia, where they decided to use workshops instead. So it's kind of like a separate but equal approach to consumer engagement. While the real guideline group is in one room, you take the consumers, you put them in another group, and you have them give you some ideas on outcomes and issues. And they got a new topic out of it. They had more buy-in from the consumers. They felt it was more focused. They did a plain English summary. I guess they conclude it's effective, but I wouldn't want to be the consumer in the separate but equal work group kind of down the hall. I'd want to be on the real group. And I think anyone here who is asked to participate in a guideline panel, if you're not going to be a full-fledged equal member of the work group with everyone else there, don't do it, because it means they don't respect you from the start. I mean, that's the standard now. You got to be on the group. This was a guideline we did recently on, I said, the fluid in the kids' ears. And let's see, Sandy Walsh up there is a member of Q. She was one of our consumers. But this is the stuff we put in the plain language summary. And this appears as a separate publication. It's got a lot of pictures. It's got a lot of interesting sheets in it. But we really developed this with the knowledge that consumers are going to want to read this information, know about it, and trying to read the 35, technobabble guideline is not going to help them. So this is written specific. It's like the Cochrane plain language summaries, but it's a bit more elaborate. And the key is the group. Who's on this group? So when we did our update of this ear fluid guideline, we had a bunch of folks here. You always need your grassroots people and people from leadership in your organization, so when nobody likes it, you can blame it on the leadership that was on your panel. This was a smaller group because it was an update, but importantly, we had two consumer advocates. One was a member of an advocacy group for middle ear disease. The other was Sandy Walsh, and some allied health folks. So that's a nice balance of a group. And these are some of the products that come out. So these are some of the patient information sheets that can be downloaded from the web. Here's one on what is this ear fluid thing, what does it mean? A lot of babies, they fail their screening when they're born because they have fluid in the ears, and it raises a whole host of worries and concerns for the parents, so we have information on that. And I see these kids in my office, I just print these out and hand it to them. My goal, when we design a guideline, I think about, if I'm seeing this patient in the office, what would I like to have to be able to hand to them to make my life easy, know that they're going to listen to what I say, understand what I say, without having to spend an hour explaining everything. And here's this was the first time we did one of these decision grids in our guidelines, and this one gives you a choice between waiting it out versus getting ear tubes versus adenoid removal for fluid buildup, and it covers the bases, what's involved, how long does it take, what are the side effects, what are the benefits, what are the risks. It's a good decision-making tool, and especially if you have ambivalent caregivers, it's good to give them this and say, think about it, and it'll help facilitate the discussion. I've been really getting into group development processes. I think it's a lot of fun. How am I doing, Barbara?
We have a couple more minutes.
I got at least 5 minutes, relax. So the key to this is facilitation. If you don't have a good group facilitator, you are sunk. And that group facilitator has to reach out and engage the consumers, or else you get the polarization. That's when you get all the people with common sense on one side of the room, and then all the specialists start drawing everybody into them, and you start disagreeing on everything. And sooner or later, you get so tired of disagreeing that you just do the groupthink where you all agree just to get out of the room, right? And then in the hall, you say, I really didn't agree with that, but I just needed to get out of there. You don't want that. So you need good facilitators, a chair that's going to really speak to you, set the stage, and be sure everybody participates, bring out the consumers if they're quiet, bring out everybody if they're quiet. The specialists like to really chat. I love the stages of group development. If you've been on a guideline panel, this could describe guideline panels perfectly, the forming, storming, and performing, and all that stuff. So you form, everybody gets to know each other. And this is where we really need the consumers to be the adults in the room and set a standard of behavior for everyone else. And then you get to that first meeting where everybody pretends to be part of the same team, but you're really there just to get your own way. and especially the specialist. So that can get nasty sometimes. Every once in a while you skip this and you're very happy. And then by the time you get to know each other, you come to the second meeting, you're all friends. Hey, we're having a great time. We're on this team. You know, we're doing great things. You know, and you finally get something done, and then you can all leave and go back to your lives. But this really does happen, and I find thinking about these stages useful. I got 2 slides left, Barbara. GIN Public. If you want to see something useful, go to the GIN website, Guideline International Network, and you will find their toolkit on patient and public involvement. It's open access, and it has some great chapters in it, some of which have been recently updated, about qualitative research, facing barriers to participation. They really put a lot of work in this, and it's a very nice toolkit. My last slide is to convince you to come a little ways in March and just drive up a little bit to New York, where you can go to the affectionately named EGAPS 3 conference. And I know Angina was there, and plenty of others have been there, but we have a pretty finalized program at this point, and we're also doing it in conjunction with Q, right? So I think Q is going to be on the Sunday, Taddy, and then the GIN meeting, really EGAPS meeting, will be on the Monday and Tuesday. So, and we're looking to get a lot of funds to support consumer engagement. Consumers will be on all the panels, here, there, and everywhere, and it should be a nice time. So we look forward to seeing you all up in New York in March. Thank you very much.